with effective interventions during those different periods. And we need to target those major drivers of infection, which I've mentioned. We need these interventions that primarily involve preventing, firstly, of course, acquisition of HIV during pregnancy. So we want to reduce the number of women who are seroconverting in pregnancy. We need effective antiretroviral treatment, and I'm going to talk more about that. We need to maintain our mother on ART, and we need to keep her in care. And that's for the duration of not just pregnancy, but there's also, we know, as I pointed out, significant risk during breastfeeding. So we need to work hard to do that. And then we need to appropriate obstetric management, post-exposure prophylaxis for the baby, and appropriate breastfeeding practices. And I'm going to talk about all of those this afternoon. So before I start the case, just a few words about HIV and antiretrovirals and birth outcomes. We know that maternal HIV infection and ARVs are known to be associated with adverse birth outcomes. Now, the data is mixed, and I could have shared many different studies with you. This is Chen et al. Carried out a survey of about 6 antenatal clinics in Botswana. They looked at obstetric records of 33,000 pregnant women. That was between 2009 2011, and they found that 30% of those women were HIV positive. And then they looked at birth outcomes in the different groups, and what they found was that maternal HIV was significantly associated with stillbirths, preterm deliveries, small for gestational age, and neonatal death. They also found significantly that compared with all HIV-infected women, those that actually started ART before pregnancy had a higher risk of preterm delivery and small for gestational age and stillbirths, suggesting, which has also been suggested by other studies, that ART also has an association with birth outcomes. Now, I'm not sharing that data with you today, but the protease inhibitors seem to be the main culprits in that regard. And there's also some associations with the NLTI backbones. The other thing that was significant in this study was that low CD4 and others was independently associated with stillbirths and small for gestational age. So what does that mean? That means that this is patients with advanced HIV need special attention. Now, they need special attention when they're not pregnant, but they certainly do when they're pregnancy, because it has been shown to affect outcomes. Okay, so I have 2 cases. This one is very brief, and then the other one is a bit longer. The first case is of a 9-month-old baby who came to Newlands Clinic with shortness of breath. He tested HIV positive in the local clinic, and we diagnosed him with presumptive PCP. His mother reported that she was HIV negative at booking, and she booked early. And she had a test. She didn't know her partner's status, which is surprisingly common, prior to attending Newlands Clinic. So the baby was very sick and needed to be admitted. And at Newlands Clinic, both of the parents unfortunately tested HIV positive. Now, when we questioned the mother, she reported that actually she was treated for vaginal discharge syndrome at around sometime in her second trimester. And actually, on further questioning, she said that she can recall a period of time during the second or early third trimester where she had a flu-like illness, a history of sore throat. She said possibly she had a fever, and she definitely had a fever, and she maybe had a rash. At this point, if this was happening now, obviously we might all be thinking about COVID, but this was back in 2019. So at this point, our impression was that she had likely undergone HIV seroconversion in her second trimester. Now, I've used this case really to remind us that these patients who seroconvert during pregnancy have a very high viral load. Often, the virus is replicating, and you'll find over 1 million copies per mil. So what that means, because we know there's a direct correlation between the viral load and the risk of transmission, that the risk of MTCT in these patients, in these women, is extremely high. So this is really just a reminder slide to us that PMTCT starts before the HIV diagnosis. the South African data suggests that around about 4% of women who initially test HIV negative in early pregnancy test positive later in the same pregnancy. So what does this mean? It means that we need to be regularly repeating the testing. As I've just said, if new maternal HIV infection is undetected, the risk of MTC is much higher. But if we detect these infections, then it enables the women to be started very quickly, and then that infant can be identified and managed as an HIV exposed. It also repeat testing also addresses this issue of false negative results, which we absolutely know does exist, and it's essential to make sure we pick these up. So these recommendations are mostly from the South African guidelines, but our guidelines are very similar. It's recommended that all pregnant women should be tested routinely for HIV at booking. Now, this is done very well, and we have very good coverage. In our guidelines, it said it should be then done again in third trimester. South African WHO guidelines suggest every 3 months during pregnancy and breastfeeding, and then again at 6 weeks postpartum. Now, I'd also like to add, and I think this is very relevant in the case I've just shared, that we should also be testing when clinically indicated. If a woman comes during pregnancy with symptoms of an STI or a confirmed STI, we already know that this woman is at high risk of acquiring HIV during pregnancy, and so we should be testing all of these women. And of course, in this case, this woman was presenting with very classical symptoms of acute HIV in pregnancy, and anyone with rashes or fevers should absolutely get an HIV test if we're suspecting seroconversion illness, because if we detect it, we can immediately initiate ART and reduce MTCT. So I'm going to go on to really the main part of my presentation, which is about a case that we managed in November last year. So this was a 39-year-old who was referred from a primary clinic in Sunridge. She was actually referred for a management of her recurrent genital ulcers, which they were struggling to control. So she described recurrent genital ulcers for the previous 3 years, but she'd said in the last 6 months she'd had increasing frequencies of these episodes, and actually the ulcers had persisted despite treatment with genital ulcer for syndromic genital ulcer disease. So she was 30 weeks pregnant when she came to Newlands Clinic. She'd had 6 previous pregnancies. Unfortunately, our obstetric history was limited. I'm not sure that the outcomes of these pregnancies, but she reported she had 2 children alive, and both of these children were HIV negative. She'd had HIV for a very long time. She was diagnosed in 2001, and she accessed private care in 2002 and was started on Tenalam and efavirenz, which, as you're all aware, was our first-line treatment for a long time until our recent switch to dolutegravir. Our information around CD4 and viral load was largely unknown prior to her coming to Newlands Clinic, but she reported that she'd had good adherence to ART. So when we examined her, we looked for any clinical signs of immunosuppression. We didn't know a CD4 count at this point. She didn't have any oral candida. She didn't have any lymphadenopathy, no skin rashes. She had genital ulcers, which we thought were consistent with HSV, but otherwise she was well. So we made an assessment that she was a 39-year-old who's 30 weeks pregnant. She had genital HSV, but at this point her immune status and her virological control were unknown. So this is a red flag for us when we're managing a woman who's pregnant with HIV. Anyone with an unknown viral load or an increased viral load needs urgent care. So we did some baseline bloods. We treated her for her herpes. We continued her first-line ART at this point. We wouldn't switch without any details. And then we carried on her prophylaxis and reviewed her within a week. I would suggest that a patient like this should be reviewed as soon as possible whenever the viral load result is available. So she came back a week later. She now came with her partner. He reported to be HIV negative. She actually, at this point, because of the results that we obtained, admitted to intermittent adherence. actually over the past year. She had multiple psychosocial issues, and she'd been struggling with getting to clinics and taking her tablets. Generally, she was fit and well. She had no clinical issues. Her ulcer seemed to be improving. So these were her significant results. She had a microcytic anemia, and an extremely low CD4 count, 26 cells per millimeter cubed, and also a very high viral load. Anything over 100,000, we'd consider a high viral load. So 110,000 copies. So we made an assessment at this point that she had advanced HIV. She was in her 3rd trimester of pregnancy. She had virological failure. I'm going to talk more about the definitions of these because it's important in management. She also had microcytic anemia and herpes simplex. So we gave her some iron tablets, we continued the acyclovir, and we decided that probably we were going to continue the acyclovir until or after delivery with that significant immunosuppression. We thought she actually had chronic HSV, and we were going to keep her on suppressive therapy until after the delivery. So at this point, we decided that we were going to switch ART. And what I'm going to do is just discuss some of our decisions with a little bit of evidence, and talk you through that as I go through the case. So one thing that we do before we switch anyone away from tenofovir is check the hepatitis B status. Tenofovir is a drug that is used not only in the treatment of HIV, but also in hepatitis B, as is lamivudine, which she was also taking. And our concern is that if we switch away from tenofovir to another drug without checking the hepatitis B status, that the patient can then have a hepatitis B flare. Now, that obviously is particularly significant in a pregnant woman, and we want to avoid that. So we checked a hepatitis B status, which was negative. After switching, we decided to do a viral load at 1 month. I'll talk more about viral load monitoring in these patients who are high risk. And really importantly, we offered comprehensive adherence support. Switching drugs does not necessarily mean that a patient will then take the new drug. And we know this from our pregnant, non-pregnant patients. So she was referred to our mental health department, and her partner was also involved with the counseling. We offered to retest the partner. That was a very high viral load. We were concerned about transmission to the partner, and we were, if negative, which he was, we offered him PrEP with tenalam, which he accepted. So I'm just going to talk about some of the decisions we made. If we look at the Zimbabwean guidelines and the WHO guidelines, treatment failure is defined as an HIV viral load of more than 1,000 copies on 2 consecutive samples at least 12 weeks apart, despite optimal adherence. So what does that mean? Practically what it means that goes on when we assess someone with a detectable viral load, we talk to them about adherence, we give them adherence support, and then we repeat it in 3 months. Now, obviously, in pregnancy, we don't have 3 months to wait with somebody who's got replicating virus. If we look at this flowchart here, which is also from our guidelines, I want you to look at the green section. If a woman comes already on ART and pregnant, like our patient, we should do a viral load at first antenatal visit, which we did at Newlands, and then it recommended that we review the result within 2 weeks. Now, anyone in the 3rd trimester particularly, we need to review that as soon as possible. If the viral load is above 1,000, the recommendations are that we should treat as possible treatment failure and repeat in 1 month. Now, we didn't do that because this woman is now 31 weeks pregnant. In a month's time, she's going to be 35 weeks pregnant. Now, I know that we knew that she wasn't taking her treatment very well. Now, what the supporting evidence for immediately treating the switch was that we knew from her adherence history that she'd been taking the drug badly. And we also know that efavirenz has what's called a very low genetic barrier. So that means that you don't have to miss many doses of efavirenz to develop mutations. Efavirenz only needs 1 resistant mutation, and then it will no longer work. So with the history that she'd given us, we determined that actually it was very likely that her virus was resistant already. And that means that even if she took her efavirenz perfectly for 1 month, it was very, very unlikely that her viral load would go down, and we would have wasted a month. And she already had a very high detectable viremia, which is associated with a high risk of MTCT. The very good news, and I'm going to talk more about dolutegravir, is that it has a very high genetic barrier. So developing resistance to our new first-line drug is much harder, which is good news for our patients. Okay, so we switched her quite quickly. Now I'm going to talk a little bit about dolutegravir in pregnancy because it's been the subject of many conferences in the last 2 years. So this is the WHO guidelines from 2008 for drug regimens for patients who are failing first line and then the preferred second line. Now, things have got a bit more complicated as we transition from efavirenz to dolutegravir, but our patient was taking 2 NRTIs, so it was on tenofovir and lamivudine, and efavirenz. And the recommended second-line regimen here is 2 NRTIs, which we did, and dolutegravir. Ideally, we should have switched her from tenofovir to zidalam. We couldn't give it to zidovudine, sorry. We couldn't give her zidovudine because she was anemic with an HP of less than 10, so we used abacavir instead. So according to the WHO, we followed the guidance. Now, in 2019, the MOH issued an addendum to our guidelines around antiretroviral therapy, which I've shown you here. And the recommended first-line regimen, if you see over here, in adults, men, women, adolescents, and pregnant women after the first trimester, was tenofovir, lamivudine, dolutegravir. So these are our current guidance. What you can see below is that the recommendation in pregnant women in first trimester or childbearing potential with no effective contraception is our old first line, which is tenofovir, lamivudine, and efavirenz. So why have we got these recommendations around avoiding dolutegravir in first trimester and those women who are trying to conceive? I'm just going to very briefly give you the background to that, and then I'm going to give you the 2020 update, which does change things a little bit. So the background is that there was a large study called the Soprano study looking at birth outcomes. It was a surveillance study performed at government maternity sites in Botswana, and it started in 2014. The primary aim of the Soprano study was to evaluate the neural tube defects prevalence associated with ART exposure at conception. So in May 2018, there was an unplanned analysis from the study that was reported and observed an increased NTD prevalence with dolutegravir of 0.94%. And when compared to the non-DTG ART at conception, which was 0.12%. So this unplanned analysis was obviously shared and published. And as a result of that, the new wonder drug that was dolutegravir now was issued with a warning that perhaps it shouldn't be used in the first trimester. So this cohort was continued, and then in April 2019, we got some slightly better news at the International AIDS Society meeting to say that actually there was still a risk. The NTD prevalence with DTG was still there at 0.3%, but it had decreased versus 0.1% with the non-DTG drugs. So at this point, and this is really with this data that the WHO issued their guidelines, that actually there may be an increased association with dolutegravir of neural tube defects, but it wasn't perhaps as significant as we first thought. So the guidance then was that women could be given dolutegravir, but they needed to have counseling to know that there was a potential increased risk. And there are many, many other benefits of dolutegravir that I haven't spoken about, which possibly outweigh this slightly increased risk. So that was in 2019. Now in 2020, with further follow-up, we see that the NTT prevalence has further reduced. If you look there in the red box, in the DTG group, there was a prevalence of 0.19%, and in the non-DTG group, 0.11. So what we're seeing is that difference is getting smaller. And I think that's just really good news in terms of our DTG use. So although our own guidelines have not been updated following that addendum in 2019, many of the WHO and other bodies, advisory bodies, are saying that DTG can be used, but women need to be counseled about a potential very small risk. Okay, so back to the case. She is now 33 weeks pregnant. She's been 2 weeks on second line. She reports very good adherence to her second line at this point. No side effects. We talked about toxicity. She'd been to book with a private obstetrician. She thought her ulcers had resolved. And we, at 2 weeks after starting out, take toxicity blood. So we're just looking at her kidneys and liver function and monitoring her HB. So we did those bloods, and as planned, we brought her back at 4 weeks in second line. So at this point, she's 35 weeks pregnant, and she was well when we saw her, and we took a viral load. So this is when the story gets a little bit concerning. So she had an urgent result, which showed that she now had a viral load of 33,000 copies. Remember, the baseline viral load was 110,000 copies. Now, the reason that I wanted to share this case is that in many situations, we have seen patients like this, and written in the note is viral load reducing, continue therapy. So I want to ask you, is this an appropriate viral load response? So in 4 weeks, she's gone from 110,000 to 33,000. Now it looks like a decrease. So I think many people would be happy with this, but what are we actually taught? We're taught that previously with our older drugs, with NNRTIs and protease inhibitors, we can expect maybe a 1 log drop at week 4. So what does that mean? If a woman has a baseline viral load of 110,000, when we do a baseline, then at week 4, we'd expect around about 11,000 copies. So already I'm concerned that this is an inadequate virological response. What about with our newer drugs? Well, one of the benefits of dolutegravir is that it is associated with rapid virological decay, meaning that it suppresses the viral load very quickly. And actually, the curve looks more like this. So from recent data in pregnant women, which I will share with you, the median time to complete suppression with dolutegravir is round about 30 days, as compared with the median time suppression of on efavirenz of 70 days. So you can see that she should have been very close to being suppressed at week 4 on dolutegravir. So 33,000 is absolutely an adequate response. So what did we do? So our approach to a woman with a detectable viral load is the same whether they're pregnant or not pregnant. And we go through a series of 4 really important questions. Obviously, the most common reason that somebody hasn't got a suppressed viral load is that they're not taking the medication. Now, we talked to her about adherence, and she previously told us that she hadn't taken it well, but she said that she'd been taking her medication extremely well, and her partner had been monitoring as well. So we thought she was probably taking the medication. What about malabsorption? Is she actually absorbing the medication? Now, certainly in the first trimester, as you're all aware, there's hyperemesis can lead to very severe vomiting, and I've certainly looked after patients who have had detectable viral loads during their first trimester because of very severe vomiting. So she denied any vomiting or diarrhea, but it's a very important question, particularly in pregnant women. Then we looked at her medication. Was she taking anything else? Was she taking anything that essentially will make those dolutegravir levels subtherapeutic, which then allows the virus to replicate? And this doesn't just mean medication prescribed from clinicians, but a very thorough history of over-the-counter medications, and of course, herbal medications, anything that might interact with dolutegravir. The good news about dolutegravir, another bit of good news, is that compared to efavirenz protease inhibitors, it has many fewer drug-to-drug interactions, but there are still some significant ones which I'm going to share with you. You also have to consider PK issues, which will alter drug levels. Those really aren't very relevant for dolutegravir, but certainly atazanavir and darunavir levels have been shown to be reduced in the third trimester, and is definitely a consideration in some patients who may be taking these drugs. So what we did find out is that she reported drinking very large amounts of sour milk. Now, what is the relevance of this? And I'm going to talk a little bit about this. So our assessment at this point is that she definitely had an inadequate response to second-line therapy. She had a high-risk pregnancy. We now have a detectable viral load in the third trimester, which we know is an emergency situation. And what we thought is, and this is something that I'm going to share with you, is that possibly she had a drug-to-drug interaction, which was leading to subtherapeutic levels of dolutegravir. So I said that dolutegravir doesn't have many DDIs, but this is something which I think is particularly relevant to us and to you as obstetricians. So polyvalent cations, so I'm talking about calcium, magnesium, iron, aluminium, have been shown to reduce dolutegravir levels. What happens is that those cations cause chelation in the GI tract, so they lead to decreased absorption. So all of the things that we prescribe commonly in pregnancy, antacids, supplements, multivitamins, they all contain polyvalent cations in varying amounts. So this is really a reminder that we need to be reviewing medication at every visit to ensure that patients are, if the patients are taking these medications, that they're taking them safely. So the recommendation is, obviously some patients need these supplements, is that if the patients are taking dolutegravir with the supplements, with the polyvalent cations, we should be advising that they take the dolutegravir, the ART, either 2 hours before the supplements or 6 hours after. The other thing that can be useful is to take, if they are taken together, is to take the supplements and the ARVs with food. But I think the easiest thing to tell patients, which is what we tend to do, is take your supplements in the morning, or take your ARVs in the morning, because DTG is usually better in the morning, and then take your supplements in the evening. And then you know that these are spread out and they shouldn't be causing a problem. So our theory, which is still just a theory, is that maybe with very large amounts of milk, she was getting a lot of calcium, and that was possibly affecting the absorption of the dolutegravir. So I've only talked about interactions with dolutegravir because I think most of the patients that we're all going to be managing are going to be taking DTG, but there are, of course, important interactions with other ARVs. One of the interactions that I thought was relevant to you was the one between proton pump inhibitors and atazanavir. These should not be given together if possible. I know that gastroesophageal reflux is common in pregnancy, but what happens is atazanavir needs an acidic pH for absorption. So proton pump inhibitors increase the pH, and the absorption of atazanavir goes down, and it can cause virological rebound in pregnancy. So please do review medications in these women because it can lead to virological failure. So I now want to talk a little bit about this particular group. This is a woman in her third trimester who is at high risk. Uncontrolled HIV in third trimester is common. As a significant proportion of women present late for ARVs, and we know that it's associated with an estimated 7 times increased risk of infant HIV transmission and a doubling of infant mortality in the first year of life. The period of greatest risk is during labor and delivery, but we are seeing more and more transmissions during lactation. And I've said it before, but I'm going to repeat it, that the peripartum HIV transmission is strongly correlating with the prevailing maternal viral load. The US study called the Women's Interagency HIV Study Cohort found that higher viral loads were also associated with increased risk of pregnancy loss through miscarriage or stillbirth. So lots of reasons for us to be concentrating on reducing the viral load as rapidly as we can. I'm going to briefly show you this data from the Dolphin 2 study, which was presented, published in Lancet this year. This was an open label RCT done in South Africa and Uganda. Adults 18 years and older with untreated HIV initiating to more than 20 weeks gestation were enrolled. They were randomized to either get dolutegravir or efavirenz, and there were around about 130 participants in each arm. The viral load was then measured at day 7, day 28, and at 36 weeks, and then the postpartum visit anywhere between 0 and 14 days. The primary efficacy outcome was a viral load of less than 50 copies per mil at the first postpartum visit. And the primary safety outcome was the occurrence of drug-related adverse events in the mothers and the infants until the postpartum visit. There is still longer-term follow-up ongoing, which I think will be important data. So the results showed, which I've alluded to earlier when we were talking about virological decay, the median time to viral load to less than 50 copies with DTG was 28 days. So it's really very quick. And with efavirenz was 82 days. And then using the threshold of 1,000 copies, which is what is classified as treatment failure by the WHO and is significant in terms of MTCT, the median time to viral load of less than 1,000 copies with dolutegravir is 7 days. And efavirenz 23. So this is really good news in terms of our new guidelines and using DTG as our primary, as our first line regimen and being able to use DTG in pregnancy. We can get that viral load down very quickly. The secondary outcomes of Dolphin showed that generally the ART was well tolerated across both groups, which was not surprising. One thing was a little bit worrying was that there were more mothers in the DTG arm than the efavirenz group that reported any type of serious adverse event. Now, DTG use in pregnancy, although I've shown you some data about it being safe, is still very new. The finding was driven by a higher overall frequency of events in the pregnancy, puerperam, and perinatal events. But if you look at those events, most of these were women who had prolonged pregnancy beyond term with or without other conditions, and they then went on to have C-sections. About 9% of women in both groups had cesarean sections. In the study, there were 4 stillbirths reported, 3 in the dolutegravir group and 1 in the efavirenz group. It was an important reminder that syphilis is a serious condition in pregnancy. I'm sure I don't need to remind obstetricians, but I certainly needed reminding. And so 2 of those women had maternal syphilis. 1 woman had was very sick, had malaria and presumptive pulmonary TB, and the woman in the efavirenz group had a post-term delivery and fetal distress. So the good news is in this study, there was no difference in the prevalence of congenital abnormalities. So what am I trying to do by showing you these results? This is really just showing you the results in a graphical form. If you look at the top graph on the left, this is showing the proportion of patients with a viral load of 50 copies per mil. The red line is the dolutegravir group, and the blue line is the efavirenz group. The dotted line is the median time to delivery. So if you look at that, nearly 80% of women in the dolutegravir were suppressed to less than 50 copies, but there's a significant difference between DTG and efavirenz. So really, I think that this is telling us we should not be using efavirenz in the 3rd trimester, and we should be using integrase inhibitors as often as possible. Okay, so she's now 37 weeks, and she told us that she stopped drinking milk. Her partner had been observing her adherence. She had recurrent HSV because she actually did stop her acyclovir, but she would very much like to have a normal vaginal delivery, which she'd had with her previous pregnancies. We planned at this point to do an urgent viral load. So she's now been week 7 on 2nd line. And from the data that I've shared with you, she should be very close to being suppressed. We also thought at this point it was very important to get other people involved. With any high-risk patient, really in any specialty, when you have to involve other specialties, preemptive discussions are really important with these patients. So we talked to her pediatrician and had discussions with the obstetrician involved. So her viral load from that day, so we're now 37 weeks, was 6,600 copies. At this point, my question is, what is the appropriate mode of delivery? And I'm sure that actually you already know the answer to all of this. These guidelines, these are actually American guidelines, but I like them, and I've given you the link below because they have a very nice discussion of the evidence, which I thought I didn't have time to show you to support these recommendations. So in America, they recommend, and worldwide, in fact, a cesarean section at 38 weeks in any woman who has a viral load of more than 1,000 copies. So this is our woman who had a viral load of 6,000 copies. Or in women, of course, who have unknown viremia, which is often the case, obviously, in our setting. In these women who have viral load of 1,000 copies, I just draw your attention to this here. If they present in spontaneous labor with ruptured membranes, there actually is insufficient evidence to determine whether cesarean section delivery reduces the risk of perinatal HIV transmission. So at this point, if a woman has a detectable viral load, but they're in labor, then I think that it's an individualized decision, and I'm sure that that is what has already been happening. However, in women who have viral loads of less than 1,000 copies, of course, we know that cesarean section delivery is not should not be performed solely for PMTCT. And then in women who have an undetectable viral load, the duration of ruptured membranes doesn't seem to be associated with an increased risk of perinatal transmission, and is also not an indication for cesarean delivery. I'd be really interested to know if what is happening clinically, but certainly if there is no detectable viremia, then the risk of transmission remains low, which is good news. So WHO has much less extensive recommendations, but supports that elective cesarean section shouldn't be routinely recommended to women living with HIV. And then there are further guidelines from that same website that I shared with you about some of the procedures that should be avoided in women living with HIV who are not virologically suppressed. And I will leave you to look at those. So what about intrapartum and postpartum care? Timing delivery, there was a comparison of 613 women who, this is a South African study, I'm sorry, I haven't put the reference, who had less than 1,000 copies, who delivered vaginally at 38 to 40 weeks. And they were compared with 300 women who delivered vaginally after 40 weeks. And this study demonstrated there was no difference in the transmission rate by estimated gestational age at delivery. So suggesting that women without an indication for cesarean delivery or prevention of perinatal transmission should be delivered according to standard obstetric indications. However, scheduled cesarean delivery at 38 weeks, as with our patient, is recommended for women who have an RNA of above 1,000 copies. So what about intrapartum ART? In the States, in Europe, if a woman has a detectable viral load, it is recommended that the woman should receive IV zidovudine. Now, I've been asking various pharmacists today about whether that's available in Zimbabwe, and I think that the answer that I got was that it's not. I'd be interested to hear from you whether anyone uses it. So if a woman presents in labor with an unknown RNA, or if they have a very high viral load, that would be the international recommendation. WHO and the South African guidelines say that a woman who isn't on R2 has a high viral load should certainly be commenced, should have a single dose of nevirapine, and the South African guidelines say Truvada, but we would use tenalam as prophylaxis. Another approach that has been used and is in the British guidelines, which I haven't included here, is to give the woman who's got a very high viral load, who is intrapartum, a double dose of tenalam or tenofovir, because studies have shown that this actually crosses the placenta well and has high levels of in the neonate. So could be considered in our patients who we know have very high viral loads, and if we don't have access to IV zidovudine. Postpartum, of course, the neonates who are delivered to these women with high-risk mothers should be given immediately high-risk prophylaxis. Now, our guidelines say dual therapy with zidovudine and nevirapine. Sometimes we can't get single formulations, so zidolam nevirapine is also used and is also effective. But what's important here is that we need to very closely liaise with our pediatric colleagues. This is also taken from the South African guidelines, and I like it because it's very comprehensive. It's discussing post-delivery care in high-risk women. I'm sure that this is this is bread and butter for you, but I think the things that are important are that we have to initiate our exposed infants on ARV prophylaxis immediately after birth. If we know that if the woman we're looking after has a very high viral load, that treatment, the sooner it's given, the more effective it's going to be. And then this part about counseling, all women need to be counseled about consistently taking their ART. And we know that we lose women to follow up after delivery and during lactation. So there needs to be emphasis on the mother continuing her ART and the infant obviously getting the prophylaxis. Breastfeeding discussions need to be had, and then discussions around mixed feeding, which I'm not going to talk about now. So what happened with our patient? 39 weeks, she had a cesarean section. It was uncomplicated. The baby was started on immediate high-risk prophylaxis with zidovudine and with nevirapine. She came back at 6 weeks, and baby had a negative birth PCR, which is important in these high-risk women, and also at 6 weeks. The mother was well at the 6-week check. She was breastfeeding and she had an undetectable viral load, which was excellent. The slightly bad news at the end of my story is that she has DNA'd 3 appointments since May, and her baby hasn't had any repeat testing, which is definitely of a concern, certainly because of those psychosocial issues that I mentioned, which I imagine that she's still dealing with, and it may be that her adherence to antiretrovirals has been affected, particularly during this time of COVID. So there is concern now still about transmission during breastfeeding, and we are making attempts to get hold of her and try and test the baby. So, in summary, detecting and preventing new HIV infections should be prioritized, and it is really critical to decrease mother-to-child transmission. ART is really the mainstay of MTCT, and it's essential for maternal health, of course, for preventing MTCT, and I didn't talk about it, but also for public health and preventing onward transmission. I haven't really gone into it, but as with our case, prevention strategies are available for prevention of transmission among serodiscordant couples and should be considered in women who have offered in women who have negative partners who have high viral loads. Of course, if there's a serodiscordant couple and the mother is suppressed or the woman is suppressed, then her partner does not require, we know, preventative therapy. Generally now, I think that the ART selection in pregnancy is going to be quite straightforward. Now that we have the data from the SEPAMO study, most women are going to be getting dolutegravir, but just a reminder that we need to counsel our patients about risks, and data is changing, and that's what we've experienced over the last 2 years. So we need to keep up to date, and we need to keep our women informed. ART reduces the risk of transmission. We should initiate as early as possible. Despite giving ART, what is clear is that women with HIV appear to have more adverse pregnancy outcome than women without HIV. So again, that just emphasizes the importance of giving high quality antenatal care. And that has many components. We need to make sure that we're regularly monitoring viral load and giving constant adherence support to ensure that we keep the viral load undetectable. High viral loads correlate with an increased risk of transmission. And then we need to concentrate on this high risk group. For pregnant women who have not achieved viral load suppression, then the things that are essential are assessing for adherence, tolerability, dosing, thinking about possible absorption problems. It's not so relevant with dolutegravir, but some ARVs have food requirements which can affect absorption, and then thinking about possible drug interactions. it's important to consider switching ART rapidly. This is not the same as an adult who is failing therapy. A woman with a detectable viral load doesn't have 3 months in which to improve adherence. And in some women, specifically our case, they maybe don't even have a month. So rapid ART switch is really essential. And then early involvement of a multidisciplinary team is recommended. Cesarean section and intrapartum ART are recommended for these high-risk women who have viral loads of above 1,000 copies around or at delivery. So I hope what I have shown is that managing women who are pregnant with HIV is multifaceted. It involves many different components, both obstetric management, medical management, patients need counseling, patients need social support. There are many risk factors for perinatal infection, and all of these interact. So if we want to maintain a woman's health during pregnancy and ensure that we prevent mother-to-child transmission, we have to address all of these different factors for us to be successful. And certainly, we've seen success in the country with our PMTC program, and I hope that that will continue. So thank you very much for listening.
Thank you very much, Dr. Lowe. That's very informative talk. We really appreciate being reminded about HIV. We're all now just worrying about COVID, but we need to remember all the enemies. So I'm going to invite questions and comments. Please, if you've got any comments, you can show by raising your hand, or you can type your comment or a question on the chat box. If you can't raise your hand, maybe just unmute and ask your question. Maybe while you're waiting for people to have their questions, I just a few quick questions, Dr. Lowe. Firstly, for this lady, what sort of contraception advice was she given? Just looking at the scenario, she, just in case she might come back pregnant again. And then this loss to follow-up is not due to the COVID restrictions. I'm not sure you won't be able to find out, but I suspect that since maybe April or so, it was quite difficult for people to move around. Then finally, any role for folic acid, though you know that now dolutegravir is not associated with NTDs, but would it be wise to just try and ensure that all women who potentially fall pregnant are getting some folic acid supplementation?
Okay, so regarding contraception, yes, contraceptive advice is very important. I think one of the other good things about dolutegravir, as compared with efavirenz and protease inhibitors, is there are many fewer less interactions with contraception and antiretrovirals. So that's good news for all of us because it makes our jobs much easier. And I think someone like this would really benefit from a long-acting method. At Newlands, we offer pretty much all methods. I can't tell you from the notes what she was using, but it's definitely a very important part of her care going forward. You asked about folic acid. Absolutely is recommended for all of our patients. And I think just because dolutegravir doesn't seem to have an association with NTD, we know that folic acid is helpful. So yes, we prescribe it for all of our patients in their first trimester or those trying to conceive. And your third question was this because of COVID? Absolutely, yes. And at Newlands, we tried very hard to follow up patients who don't attend. And she has actually been picking up her phone since, and she has been promising to come to the clinic, but she just hasn't been making it. So we haven't lost touch with her. And we will keep pursuing it. And if necessary, we do have capacity to do home visits. So we will definitely pursue this because I think this is still an at-risk baby.
Thank you. Dr. Nyakura, I see your hand is up.
Thank you, Dr. Madzire. Thank you, Sarah, for the nice presentation, quite informative. I have 3 questions. The first one is, we only heard about the men right at the beginning when he was tested and he was negative. We didn't hear any repeat tests for the men. was is still at risk, and what happened in terms of the PrEP? Did they accept it, and what do they do when they are not trying to conceive in terms of protection and contraception? Then my second question is, there are those patients who are well suppressed on their old regimens that have been on efavirenz or along with the viral load less than 50 or target not detected. Is there any indication to then switch them to dolutegravir? And if we do switch them, do we then, after the pregnancy, do we then switch them back to their original regimen? So my understanding is that once we have switched them to dolutegravir, we maintain them on that. So, and now the third question is, those patients that you adequately counsel and inform them the risk that the initial study showed that there's a almost a 10 times risk of neural tube defects with the dolutegravir compared to efavirenz. Most of them become reluctant to accept the switch to dolutegravir. How do we handle such patients? Thank you.
Okay, so I'll start with the easiest first. If people are suppressed on tenalam-E, what we're doing at Newlands and the general guidance from MHH is that we should be switching everybody to dolutegravir. Now, this is because of dolutegravir is going to be supplied by NatPharm and there's going to be less efavirenz available. And in these patients, we know it's very safe to switch and that patients tolerate dolutegravir very well. So as a rule, switching is safe and it's recommended. Should you switch back to efavirenz? The answer is no. If they maintain the virological suppression on the dolutegravir, then efavirenz is not, there's no need to go back. Of course, there are patients who do react to dolutegravir. It's not a perfect drug. And those patients, and we have had some of them, we do switch back. The issue of weight gain, I don't know if you have experienced this, is definitely something we're seeing.
Yes.
And we have got a few patients who've put on more than 20 kilograms in the first 6 months of being on dolutegravir. And these are patients that we're concerned about and we switch back. But if there's no clinical indication, then we would keep them on their DTG. The man, I didn't talk about the man, you're right.
Yeah.
And I think there's a whole nother presentation on PrEP. I can't tell you what he did or whether he carried on. I'll tell you what we do for these patients is that obviously in this case PrEP was indicated. We would retest him for HIV for the duration of the risk. So that would mean until her viral load is suppressed. Obviously, we don't know that she's his only partner. And we have a PrEP program that is largely run by our pharmacists, and we let people determine their own risk as well. So he's really free to stop and start whenever he likes, and then we offer him monitoring and appropriate monitoring and HIV testing. Was it acceptable to him? I'm afraid that I can't remember. It wasn't clear from the notes when I was reviewing it. And your third question, I'm sorry, I didn't write it down, was about...
well, the last question was the issue to do with the acceptance of the risk of neural tube defects in these patients. Yeah.
So I think this is difficult because if you look at the 2018 data, yes, I think that we were right to be concerned. So I think this is really an issue about counseling women about evolving data, and the strength of our recommendations is being based on acquiring more data, because that's really essentially what's happening. That over time, we've seen that the number of NTDs has decreased in this group, and it gives us a more accurate reflection of what we believe is the risk. So our data is only getting stronger, and I think that's how I would try and reassure women. However, it's okay to give efavirenz. I mean, we know that tenalam-E works. And if a woman doesn't, I think that's the whole point about the WHO statement, is that we counsel women and we let them make their own decisions. I think a lot of women were very cross in 2018 that they were told they couldn't have it, and that they weren't able to essentially assess the risk and use that information to make their own decisions. So I think as clinicians, we just have to use the data and then help a woman make the decision. But of course, the use of DTG also has benefits. So I think you need to try and weigh those up against a small potential risk.
Thank you so much, Sara.
Okay.
Dr. Verenga, your hand is up. Can you please go ahead with your question?
Thank you, Chair. Thank you, Sara, for a very informative presentation. My question is to do, I think you showed one slide with, I think it was a Botswana study with some adverse pregnancy outcomes. I think it was the 2012 study.
Yes.
Yes. So my question, because I think you just mentioned that study, and you left it like that. Yeah. So I'm now wondering whether you are saying there are adverse effects associated with the ARVs, with women taking ARVs, adverse pregnancy outcomes associated with taking ARVs. Is that the message you are putting across?
Yeah. There were two messages from that study, which I took. One is what we know is that if you compare women living with HIV and those who are HIV negative, there's a significant association with maternal HIV and stillbirths, preterm delivery, and neonatal death. So if you compare HIV positive and negative, those associations are seen. This study wasn't looking particularly at ART. I think they looked at initiating ART regimens. But what they did find was that the women who were on ART before they became pregnant had higher odds of preterm delivery and stillbirth as compared with those that started. So that suggests, and there's other data that actually goes further to suggest that the ARVs themselves do have a contribution to adverse outcomes. And if you look at other studies, the culprits that have mainly been named are the protease inhibitors. So the answer is yes. I think as we move away from the older drugs and we use DTG, perhaps that's going to be less important. But I think still the outcomes are different between HIV positive and negatives.
Yeah, because my follow-up, Sarah, is that the problem with your answer is that you are suggesting that probably these HIV pregnant women should be given a different kind of care from the non-HIV positive pregnant women. Because if you are saying they're at increased risk, then that means you should look after them in a different ways to avoid this risk. Because the summary of the data which I knew is that we didn't need to change the prenatal care of pregnant women with ARVs in terms of surveilling for this kind of complication that you have mentioned, except the issue, some of the issues you mentioned, like making sure that their CD4 is checked, the viral load is checked at regular intervals. Because if you are seeing that increased risk of preterm death, should we then say all women on ARV should have preterm surveillance, like checking their cervix to see if they are going to get into preterm death? Because these are the implications of that answer, to say these women are now at risk of preterm death.
Okay, so I understand your question. What I would want to say is that the population of women who are pregnant and HIV positive is obviously not homogeneous. So we know as a group, there is an increased risk of adverse birth outcomes associated with HIV. And that is due to many different things, including ART type, including timing of ART, including immunosuppression. So as a group, I think we can't blanketly say they don't need special care. I think we need to put them into different groups. And I hope that the case that I presented could demonstrate that. So there's a woman who's been suppressed for 10 years, who's well, who doesn't have any medical problems, and she certainly doesn't need any change in her care. But then we have these women who are failing ART, who have low CD4 counts, who maybe have other comorbid conditions, who definitely need a different or a sort of a different model of care. And I think probably that would be my answer, that we need to risk stratify these women and then change our care according to that. Does that help?
Yeah, in a part, anyway, the last comment which I wanted to make is to do with the dolichos gravi. Yes. One of the biggest problem I think we have in our region here is the issue of folic acid. Okay. Our women are not starting folic acid at the right time. Mm. So that even with that Botswana study, the history of whether these women were taking folic acid or not was very patchy. Mm. We all know that folic acid is one of the probably the best intervention in terms of reducing the incidence of neural tube defects, which most of our women don't. I'm saying this because we collect this data in all our fetal medicine units, and we've seen that probably 80 to 90% of women are not taking folic acid. If they are taking it, they are taking it at the wrong time, because folic acid, to prevent neural tube defects, you need to take it pre-conceptionally. Yeah. But what is happening is that most women are taking it in the second trimester when you know that a new relation is already occurred. Whether there's an open neural tube defect is there, whether the woman is going to continue or not. So I think this is the biggest challenge with the interpreting results of dolichos gravi in our setup, where we know that the majority of women are not taking folic acid at all, or if they are taking it in the wrong way.
So I would say that in some ways, the Botswana data is reassuring for us. Like, if this was a US study, then we would agree that the majority of these women would have taken preconception folic acid, and it would have been difficult for us to say, but our population is different. But in Botswana, as you mentioned correctly, my understanding is that cohort did not, much like our population, doesn't take folic acid well or correctly at the right time. So as we see that decreased risk in their population go down, that even without folic acid being used well in Botswana, we're seeing that risk disappear or be minimal. So we could maybe then extrapolate that and say, well, our population in Zimbabwe also doesn't take folic acid well. So maybe we can be reassured that even when it's not accessible or used correctly, still the risk is very low. But I appreciate the point you're making.
I will allow 2 more burning sessions. Dr. Mateveke, raising your hand. You can go ahead.
Thank you, Dr. Madzire. I just wanted to thank the team for organizing such a wonderful presentation, and thank you, Doc, for giving us such an enlightening presentation. It's just a comment and follow-up to Dr. Averenga's contributions, particularly the note that women are not taking folic acid on time. It essentially translates to the fact that when it comes to antenatal care, within our setting, pre-conception care is lagging so far very much behind, and maybe on a different platform when the fetal medicine unit presents, they can enlighten us on what measures they are taking to try and improve this part of antenatal care within our population. Thank you.
Can I make a point? Because you've kind of, we have a captive population. So we've got a lot of young women who are not currently pregnant. And I think actually that we should be collaborating and that we should be integrating, and many places have done this, preconception care into routine HIV management. Particularly with this data and with the concerns that we've, and in our group, we should also be talking about this. Because we see these women regularly before they get pregnant, and obviously that's the time to intervene. So I think a collaboration and working as the HIV clinicians, physicians, we should also be addressing that.
Then Sarah, on the first case, you said the mother was HIV negative during pregnancy, but the baby then was positive at 9 months. What's the uptake of couple screening at Newlands? I know it's difficult in the public sector. I don't know at Newlands.
Still, it's a challenge. I think it's a challenge worldwide. When I was working in the UK, we tried to do a study where we got partners tested, and we had quite good funding to do that. And even with all the resources and special people to go into the community to try and get the partners to come, we really struggled. So we offer it, but uptake is relatively low. And I'm always surprised by how few women know the status of their partner, which is something we really need to work on.
So, Sara, thank you very much for giving us this informative talk. It's very good revision for all of us. We hope we'll be able to invite you to present more captivating cases, and obviously this is the best mode of learning. I don't know whether there are any housekeeping issues from the committee, Dr. Matewege or Dr. Magure, if she's joined the meeting.
I do not have any housekeeping issues at hand, except maybe an update on the survey, which was shared on the various platforms. We are going to be working to see how best we can implement the results of the poll, which I think everyone else is aware of. I think we will communicate through the usual channels to update our members. And I would like to thank again Sara for such a captivating presentation. And I think when we were planning this months back for this day, you had sort of like two different topics that you wanted to present, and it seems you have tried to capture most of the issues in your presentation. I think we'll try and inbox you again and see when we can back on the platform for another captivating talk. Thank you so much, Sara, and thank you, Newlands Clinic, and everyone else.
Thank you very much.
Thanks. Bye-bye. The meeting is over.